So again, as usual, the presenters do not have a financial arrangement related to the content of this activity. And we're going to talk today about risk assessment and safety planning. It's kind of a very important topic. Objectives. We're going to sort of talk about the best practice principles for risk assessment. And I believe there is a chat. So I just want to make sure. Cool. Practice approaches to risk assessment in the course of everyday clinical practice. Look at risk factors, warning signs, as well as protective factors within the assessment process. And kind of think about the follow-up for each level of risk. How do you follow up based upon your risk assessment? So those are the things we're going to try to do. We'll start with some kind of fact or fiction, right, regarding suicide. And I think we should make it interactive. So I think I want people to either speak up or type in whether this is, they think, true or false. Number one, most people commit suicide in the winter months. Fact or myth? You got a couple of many facts, and then are not in the winter. So you're playing the statistical odds there. Most people are saying this is true. What is the answer? Let's see. It is in fact false. Suicide rates are often highest in the spring, right? Yeah, now we've got a couple of people saying myth. You guys are right. So this is actually not true. Most suicide rates are higher in the spring. It's been presumed that part of it may be that individuals with underlying bipolar illness may have some cycling into mania or hypomania during spring, and maybe that makes them more vulnerable to that, right? So that's one. Let's go to a second one. Teenagers are at the highest risk. True or false? Fact or fiction? And one person suggested that it's the elderly, and that is absolutely correct, right? White men over the age of 85 are at the highest risk, followed by men, all men over 65. Right? So it's the elderly males that we worry about the most regarding suicides. Having a close family member complete suicide increases risk. True or false? We've got several people chiming in with true. Okay. And that is in fact true. Right? So having a close family member complete suicide actually seems to confer about an 11-fold increased risk of completing suicide. So important to keep in mind. Talking about suicide increases a person's likelihood of acting on it. I want all of our behavioral health folks to chime in, and they are with resounding false answers. And that is the correct answer. That's a myth. There is no association between talking about suicide and acting on it. In fact, there is a strong correlation between failure to ask about suicidal thoughts and completed suicides. So I think therein lies the value in screening for it, right? That we should screen for it. You know, some people are afraid that if I ask about it, I might increase the risk, but there is no evidence supporting that. What about children are not at risk for suicide? Is that true or false? We've got several falses coming in here, and I believe that's the correct answer. Right? It's not very common, but it does happen, and when it happens, it's as you can imagine, extremely devastating. Right? Now, and suicide was the second leading cause of death for 24-year-olds in 2015. Is that true or false? So this one, we're getting more of a mixed answer, right? And it is true, right? Are people surprised by it? And, just something to reflect upon, right? And accidents absolutely remain the leading cause. In 2015 Youth Risk and Behavioral Survey, that found that in the previous 12 months among high school students, about 18% seriously considered suicide, about 15% made a plan for suicide, and almost 9% attempted suicide one or more times, and 2.8% made a suicide attempt that had to be treated by a doctor or a nurse, right? So that's the data. So it's certainly, certainly kind of alarming stats, attention grabbing statistics here. Now, the next true or false. Whites are the highest risk racial group. True or false? We've got several people chiming in with true, except now we've also got some false coming in. So yeah, this one's a little bit tricky, yes. And I think Alex is exactly right. Alex says, I think Native American is slightly higher. And as you can see the data, yes, so I think the highest risk of suicide, according to literature, would be AR, American Indian Alaska Native populations, and followed closely by white populations, and much, much lower within other groups. Men are more likely than women to commit suicide. True or false? Oh, sorry, I accidentally gave it away. Men die by suicide 3.5 times more often than women. Yeah, Celia says they don't ask for help. Maybe true. Also, we know that men tend to attempt by more, Whale said greater lethality rate, and also potentially greater use of more lethal means such as firearms. That brings us, I believe, to the next one. Well, no, it's not the next one, but how about this one? Substance use is the most associated condition with suicide risk. True or false? So we've got a lot of truths coming in. So this is, I think, the first one where people got stumped. So in fact, depression is the most likely condition, right? About substance use disorders are actually found only in about 25% of completed suicides, right? So this is the first one that seemed to stump most people. Treatment decreases risk. I'm not even gonna give people a chance. This is a fact. Treatment of any contributing mental health issue decreases risk of suicide, right? So let's go. So thank you for participating, right? So these are just some data on suicide. It's the 10th leading cause of death in the United States. And there are about over 40,000 US deaths from suicide each and every year. On average, one person commits suicide every 16 minutes, and each suicide intimately affects at least 6 other people, it has been estimated. And I think this is one of the important statistics, that firearms do account for almost 50% of all completed suicide. And several of you mentioned in the chat column when we were talking about gender differences that men tend to have more lethal attempts. And I think that's absolutely correct, where there is more of a use of firearms by men who attempt suicide. And that may be why they, one of the factors contributing to that higher completed suicide rate among men. And for every completed suicide, there are about 25 attempts, right? And so who are the severe suicide attempters? Like, what are the comorbidities? And I think that's important to kind of start to appreciate. And as you can see, these are some of the big risk factors, right? Anxiety. I think when I see my patients with acute anxiety, acute severe anxiety, or even akathisia related to a new antipsychotic use, I want to be very mindful of that and treat that right away, to, just simply from a safety perspective. Insomnia, right? Another big one. And, panic attacks, depression, poor relationships. But then look at some of the data that are concerning. Over 80% had no plan. So it was there wasn't a plan thought out. It was kind of a fairly, it was fleeting ideations, right? Or no ideations at all. So it was a fairly impulsive, acute act. And for 67%, it was their first attempt ever. And look at this last one. And this is why we need to be doing better. Only 28% had been asked about suicidal behavior, right? So when we talk about sort of this movement of zero suicide, right, of like really eliminating suicide, I think to me, that's sort of an easy goal. Asking about suicidality, right? Asking about it, and being aware of some of these risk factors that we're gonna talk about. Right? And also, how do you ask about it and what do you do with the information? So that's what we'll try to continue to cover as we move forward. right? So this slide is really looking at what are the, what leads to it. And we don't have one answer. Coping style, right? So it's been suggested that, kind of, in that within our mental health system, unfortunately, sometimes suicidal behavior can become a response to stress, right? Which is kind of really unfortunate. And I think maybe an indictment of the mental health care system that we do have. Impulsivity. In others, it may result from impulsivity, right? Where poor problem solving, lack of perspective, and intoxication. I think that's where that substance use comes in. That acute substance use, the intoxication, can really contribute to the impulsivity. And premeditation, whereas in still others, suicide is the long-term outcome of years of psychological suffering, right? In a person who has otherwise given up hope. So it's different for everyone. It's multifactorial. And these are all of the factors that might contribute to it, from stressors to access to weapons, to severe medical illness, to substance use, personality traits, psychiatric illnesses, neurobiology, impulsivity, hopelessness, family history, psychodynamics, right? All of these things might contribute to it. I just want to check the chat. Sandra says, I've seen more people in the ER with anxiety, depression, and suicidal thoughts due to current isolation concerns. Thank you, Sandra, for pointing that out. And I think maybe that warrants discussion, more discussion next week when we meet about what we're seeing and what might be a good way to address it. I think thank you for bringing up that point, right? So what is risk assessment? This brings up, this is kind of the next part of the illness. Now we know kind of some of the facts around it, what are some of the comorbidities around it. Let's get into risk assessment. So it refers to the establishment of a clinical judgment of risk in the near future, right? And it's really based on weighing of a very large amount of available clinical detail, right? As we just pointed out, there are all these factors that might contribute to the risk of suicide. So if we're doing a thorough risk assessment, we're at least being mindful of and thinking about as many of those factors as we possibly can. Why do we assess risk? We want to identify any modifiable and treatable risk factors that inform treatment, right? There are some risk factors that we cannot modify. For example, the gender or the age, right? Or the family history or the race. We can't do anything about it. But there are other risk factors which might give us the opportunity to intervene and hopefully reduce the risk and allow the patient to be safer and hopefully lead a better life, right? And to take care of our patients. That's really kind of the ultimate goal. But at the same time, we also assess risk to take care of ourselves. Risk management is a reality of mental health treatment, right? And it's, unfortunately, when you talk about mental health providers, many of us will experience at some point a patient's suicide. And it can be devastating, right? These are often patients that we've formed a great therapeutic relationship with, we've taken care of for a long time. And it can be, it can just be really heartbreaking and terrible to lose that patient to suicide, right? I know we have several trainees on, and about 33% of trainees have had a patient die by suicide, right? So what does it, what type of things do we look for in the risk assessment? Self-directed violent behavior or ideation. Non-suicidal self-directed violent behavior ideations, for example, cutting or other self-harm, as well as undetermined self-directed violent behavior ideation, right? Let's see, I'm gonna pull up all of these. So best practice standards of care require risk assessment be completed at the initial visit, at intake, and then whenever indicated. And we'll go into whenever indicated here in the next few slides. Effective assessments will attend to both risk as well as protective factors. We often forget about those, right? But there are some real protective factors. For example, social support, right? Or goals for the future, or a good therapeutic relationship. Potentially all of those could be protective factors, and we need to take those into account. It's a process, right? It's not sort of a one-time thing. You've done it, you checked it off. But it's a process as we work with our patients. We're being mindful of this and doing it whenever we think it's appropriate. It includes a thorough history to collect specific patient data to guide clinical judgment and it should be based on specific risk and protective factors associated with outcomes. So when is it indicated? Risk assessment. So emergency or crisis evaluations, of course, right? If you're working in an ER, if you're working in a psychiatric emergency setting, you're gonna do this. Also intakes, change in status or treatment setting. So when there's a major change, you wanna be mindful of it. Lack of improvement, or even you're seeing this gradual worsening of symptoms, right? Or if the patient is starting to experience or anticipating a significant loss or stressor, such as what was just brought up in chat, right? Maybe that insignificant stressor is social isolation combined with loss of job, things like that related to the current pandemic. Onset of significant physical illness and or chronic pain. Chronic pain is very intricately tied to suicidality, where, right, there's a clear link or association between chronic pain and increased suicide attempts as well as suicide completions. And what we know is that it's actually the pain that's kind of face and above, so facial pain, headaches, that tend to be the most closely related to suicidality. What factors are, so non-modifiable risk factors, we've talked about family history, past history, demographics, but then these are some of the major modifiable risk factors. We can do something about them. Psychiatric symptoms, right? Social support, as well as access to lethal means. What are the modifiable protective factors, right? Which is key to addressing chronic risk, which many of our patients have, right? Responsibility to family, being able to do reality testing, positive coping skills, problem solving skills. This is where, like, we as clinicians, treatment providers can come in and really offer this support, the social support, as well as positive therapeutic relationships. So these are things that we can really foster over time. So when and if a stressor acutely arises, these things are in place to hopefully mitigate some of that risk. What are some warning signs? So those are person-specific emotions, thoughts, or behaviors that may precipitate suicidal behavior, right? They're proximal, so they happen pretty close. These are the warning signs. So now we're not just talking risk factors, right? Things that a person brings with her. But now we're talking about things that happen close to the suicidal behavior and imply imminent risk, right? The presence of suicide warning signs, especially when combined with risk factors, so underlying risk factors, plus now new onset warning signs, right, generates the need to conduct a complete risk assessment with a crisis plan. And we've listed here some of the risk factors which we've gone over, along with some of the warning signs. And I just want to focus on the warning signs. I think if you see some of these, then our alarm should go off. If you're working with a patient in whatever context, and if you see some, we should be concerned. Threatening or talking about wanting to commit suicide. Patients will often talk about this. Seeking access to lethal means. Talking or writing about death, dying, or suicide. Increasing substance use. Stating no reason for living, no sense of purpose in life. Feeling trapped, like there is no way out. Anxiety, agitation, unable to sleep, which can really increase that impulsive behavior. Hopelessness, helplessness, withdrawal, and isolation. So some of the things to be mindful about. Note on firearms, which account for 55 to 60% of suicides, right? They increase the risk not just for adults, but also for adolescents. Guns are twice as likely to be found in the homes of suicide victims as in the homes of attempters, right? So again, kind of really showing us that firearms can really shift that balance between an unsuccessful suicide attempt versus a completed suicide attempt. Type of gun was actually not statistically correlated with increased risk for suicide. So risk management, always inquire about firearms when indicated and document instructions about gun storage or safety plan and the patient's response, right? New onset versus chronic risk, another important topic, right? So if someone has that acute risk, they're starting to plan, they're starting to formulate a plan, right? So patients may have, many of my patients do in fact sort of this elevated chronic risk, right? These are patients with poor social support. These are patients, again, with ongoing substance use, with underlying depression, underlying PTSD. So they have kind of always this chronic elevated risk. But I want to go beyond it. If I see some of these new warning signs, right? Or if there's something changing, something emerging, then I really want to be mindful of, is the acute risk being elevated or not? So keep in mind that chronic risk versus acute risk, right? So what factors would you look for in determining acute versus chronic risk? So, again, some of the things being any social life changes, any major life changes, any new illnesses, any losses, right? New untreated anxiety, depression, insomnia, all of these can potentially account for it. So be mindful of those, right? Know your patients, I guess, is the take-home message. We do have structured suicide risk assessment. There are several of them at our clinic at the University of New Mexico. We use the Columbia Suicide Severity Rating Scale, which is the CSSRS, but any of these really could be used. They're all validated. Now, Dr. Maley really goes into risk factors, warning signs, and steps. It's the rule of five. So what are the 5 warning signs? 1, suicidal or homicidal intention. So ruminating, thinking about it all the time. Going beyond it, are we now starting to create a plan? How might I do it? Preparing for it, right? Stockpiling pills, for example. Is the access? Do you own a firearm at home? Do you have dangerous medications at home? Giving items away can often also be a major warning sign. Second one, sudden change in mood with no known reason, right? And this is kind of well recognized that oftentimes when someone has kind of made that decision, they may have gone through this fraught process of whether or not I'm going to do it, but once the decision is made, it's like a burden has been lifted, right? And often you see this elevation in mood as things have been settled, and that can sometimes be a major warning sign. Anxiety, agitation, insomnia, despair, hopelessness, feeling like a burden to others, right? Oftentimes our patients, and can be a part of depression, part of what can make it so insidious and dangerous, right? Is this idea that I'm just a burden to others, and poor treatment alliance. They're not connected to treatment. Are 5 kind of very important warning signs. 5 important risk factors: previous attempts or exposure to violence, self-injury, aggression. I bring this up because oftentimes we come across that patient. Remember, going back to an earlier slide, it talked about the patient who uses suicide attempts or suicidality as a way to really access that treatment, as a way to access care. And unfortunately, what I've found over the years is that that patient can get dismissed, that this patient isn't serious, this patient is just quote unquote seeking secondary gain, right? But regardless, we know that prior attempts are a strong predictor of future attempts, including future completions, right? So I think, if someone attempts enough, they may just wind up completing suicide. So we have to take that seriously as a major risk factor. Mental illness, substance abuse, social isolation, stress, recent loss, family history or exposure to suicide, and Native American or white male can be 5 kind of major risk factors. And these are the 5 steps that we take. First is asking about it, right? Remember, the only 28% of attempters had been asked about it, right? Risk factor: has this client made previous suicide attempts or shown self-injurious behavior, violence, things like that, right? Warning sign: is the client showing intention to act? Always ask directly. Don't beat around the bush. I think it's okay to ask, and with good intentions, and stay calm and non-judgmental, but always ask. Right, so that's step 1. What is step 2? Step 2, ask about the mental state, right? Risk factor would be presence or history of mental illness, substance abuse. Those are things we may know about the patient, but that acute warning sign is going to be things like anxiety, agitation, insomnia, despair, sudden unexplained change in mood, sudden increase in substance use. Third, ask about social connection and stressors. Risk factor would be, underlying risk factor, things like isolation, stress, losses, exposure to suicide or violence, which unfortunately we see in so many of our patients and in our community members, right? In fact, I believe the last Surgeon General just wrote a book about the epidemic of loneliness and just how harmful that isolation can be. And I think that's sort of unfortunately, such a major part of our society. Acute warning sign can be feeling like a burden, feeling disconnected from others, from the community. Fourth would be assessing treatment alliance. Underlying risk factor would be no treatment alliance, help negation, unreliability, impulsivity, and acutely, that sudden, unexplained improvement, right? Client tells caregivers what they want to hear in order to avoid supervision. So they start saying, everything's fine, my depression's gone, I'm feeling happy, I just need to go home. And fifth, So what is the plan for reducing the risk? That's kind of what we come to. So basic plan should reduce risk factors and enhance protective factors. Safety supersedes everything. Remember, I think when one of the Suboxone talks I said, and I hold to it, that I think the only time, because of where I would not start Suboxone for psychiatric reasons, is if I was concerned about acute safety, acute suicidality, acute homicidality, where that's gotta be the priority. That's what you're gonna wind up treating, right? And if you're in doubt, ask for a consult. Ask for a second opinion. Homicidal risk assessment. So Dr. Maley's got a couple of slides on that, which is where that anger, that violence is directed outwards towards others, right? A note on Tarasoff, because New Mexico is considered a Tarasoff state or a duty to warn state. And what that means is that in the original decision, which was done in California in this case, right, it held that mental health professionals have a duty to protect individuals who are being threatened with bodily harm by a patient. So you have to break confidentiality if you're really concerned about harm to another person. And the original decision mandated warning the threatened individual, like directly. So calling up the person who's threatened and warning them. But a rehearing called for a duty to protect. And that can come from many different avenues. You can do this in many ways, right? Including notifying the police, which is often what we do, right? Notify the police, allow them to kind of intervene. And here, at least, we're fortunate to have the crisis intervention team, which has training in it and has regular echo clinics to help support them. Warning the intended victim can be another way, or taking other reasonable steps to protect the threatened individual, including involuntarily hospitalizing the patient, right? Other important things, always be mindful of your own safety. If you feel unsafe, you can't really assess risk, right? So be mindful of your own safety, evaluate the patient's situational context, perception, assess for detailed history of past act of violence towards others, right? Because most predictable variable for future risk is past behaviors. Collateral information is important. Assess for psychopathology, including substance use and antisocial behaviors. Consider suicide risk, as we've talked about. So once you've done the assessment, what do you do next, right? So if there is moderate or above acute risk, this is kind of the steps to take. If you're a trainee, obviously immediately alert your supervisor, get a second opinion, complete a safety plan, and initiate emergency protocol if there is a high risk, right? So very often in outpatient clinics, if this happens, we wind up really talking to the patient about hospitalization and activating the emergency response system. If you're a staff, again, alert supervisor, call the RN supervisor for medical evaluation for transportation and ambulance, right? Complete the risk assessment in chart and contact the PES, stands for our psychiatric emergency services. So giving a report to the to physician or resident who's working there that, hey, this person is coming over and this is what I think is going on. And C4E stands for certificate for evaluation, which basically means that I certify that this person is an imminent risk of harm to self or others and needs to have a full psychiatric evaluation. And this actually we wind up using a lot. Fortunately, often what will happen is that we might evaluate a patient and we think that the patient is really high imminent risk for self-harm. But when we tell the patient, talk to them about going in for treatment, they will say, nope, I'm not doing it, I'm getting out of here. Of course, we try to de-escalate, which is another talk, try to work with the patient. But if they leave, we can't physically stop the patient. That would be illegal and also potentially harmful to you and the patient. So I think that's where we kind of initiate the C4E process, which gets kind of the first responders involved. And it gives them the authority and the mandate to pick up the patient and transport them for psychiatric evaluation, right? Let's see here, kind of going forward, we've talked about this. If it's low risk of suicide, talk to the patient about how to access emergency services. In New Mexico, we're lucky to have a warm line as well as a crisis hotline. So giving the patient all of those resources, always a good idea. If the risk is moderate, you kind of talk about a safety plan. You come up with what might you do if things get worse? When might you seek more help? Maybe think about adding in other collateral folks, right? Support systems, other providers, etc. And level 3, if the risk is high or if there is question about the level of risk, I think that's when you really think about transferring the patient to the ER or the psychiatric emergency room for further emergent evaluation, right? And document that, right? So, note on no suicide contracts. These used to be very common, and I still occasionally see them. These are essentially these contracts that patients sign saying, I won't do anything. We don't recommend using them, right? For a couple of reasons. One is that they can provide this false sense of assurance, right? Because patient can just sign off on it. It's not legally binding, doesn't mean the patient's gonna follow it. So it can create this false sense of assurance, right? And it doesn't offer the patient any resources. It doesn't actually engage the patient, get to know the patient, and offer any resources. So I think for those reasons, you're much better off talking to the patient and doing kind of this risk assessment rather than just doing that. It should be collaborative, right? Instructions should be brief and use the patient's own words when you do this. It should be easy to read. For example, when I feel unsafe, I will call my best friend at this number. Or, I will keep the number for the warm line posted on my refrigerator. It should be easy to read in patient's own words, address barriers, include the names and numbers of emergency contacts. So all of these things really should be included in your safety plan. And then part of the discussion should be devoted to how likely, and thinking about how likely is it that the patient will use this plan and problem solve around any barriers, right? Where will you keep it? How will you access it? What barriers might you see? And if they come up, how might you address it, right? Discuss with whom and how to share the plan. Review and update it frequently, just kind of that repetition, get the patient used to the plan, and discuss the location of the safety plan, and discuss how it should be used during a crisis. Remember that most suicidal people do not want to end their lives, right? It's important to keep that in mind. They want to end their psychological pain and suffering. They want to tell others they're thinking about suicide as an option for coping with that pain, right? And often just asking a patient will give them an opportunity to share these thoughts and discuss alternative options. Have psychological problems, social problems, and limited coping skills. All things that we as mental health professionals are usually well trained to tackle. And I'll end here. We've got about 6 minutes.